I would now like to turn it over to Daniela Cramp, President of the Instrument and Enterprise Solutions Division at Thermo Fisher Scientific. Daniela?
At Thermo Fisher. I will serve as your host and moderator for today's call. I would like to introduce our panelists today, Mr. Mark Stevenson, Chief Operating Officer of Thermo Fisher Scientific, Dr. Alan Wu, who is a PhD and Professor of Laboratory Medicine and the Chief of Clinical Chemistry at the laboratory at San Francisco General Hospital. And then Julia Cheek, Founder and CEO of Everlywell, our partner in this initiative. Over the past 4 months, given the extensive involvement Thermo Fisher has in the area of COVID-19 testing, ranging from support for vaccine development to development of diagnostic and antibody testing solutions, and providing laboratory support tools to the scientific community, we have been contacted by many partners asking for a solution to testing needs in association with safely returning to work and school. Today will be the first in a series of webinars designed to educate partners on various dimensions of testing and returning safely to your workplace. We will have future webinars which will cover additional dimensions of testing, including considerations to take as an employer to define testing strategies, ranging from health and safety in your facility to the considerations you should take in setting up employee testing. We will share our own experience in doing just that. Today, we will review the currently available testing strategies in the market, how to think about these, and then we'll discuss the solution we have underway with Everlywell. With that, I would like to turn the floor over to Mark Stevenson, our Chief Operating Officer. Mark?
Thank you, Daniela, and good afternoon or good morning to you all. So today we're excited to share with you what we've been learning about testing from the front lines over the last couple of months, and also an employer ourselves, how we've been approaching employee testing. Before we get into that, just a few words to introduce Thermo Fisher Scientific to those who are not familiar with the company. Should we go to the next slide, please? So we're a very large global company with colleagues all around the world, about 75,000 colleagues. Very much we're a scientific organization. We have more than 5,000 scientists, so a lot of our colleagues asking us, what are we doing in testing and how are we approaching? Our customers that we serve are pharmaceutical customers, academic and government groups, and we have an unmatched scale and depth and capabilities across different aspects, as I'll talk about in a moment. We go to the next slide. So in terms of what gets our colleagues to work, it's really our mission. And our mission is to enable our customers to make the world healthier, cleaner, and safer. And during this time in COVID, that's been a really inspirational emotion for the colleagues to live that, supporting making the world healthier with the diagnostic testing and development of vaccines and treatments. We've also changed some of our manufacturing capability to make products we weren't making before, such as hand sanitizer, enabling colleagues to increase production there. And also we've brought on new suppliers through our channels to provide more personal protective equipment, PPE, for those on the front lines during hospital and in testing. Go to the next slide. So in terms of the details of the response we've been working through, as I mentioned, it started early on in the outbreak in China in terms of providing equipment, and then in the US and Europe, personal protection equipment. Very much at the moment, research customers are focused on understanding the virus more, and we'll share some of that through the insights of Dr. Wu in a second. What do we know about the virus, what we're learning about it, and diagnostics. Our role as well has expanded quickly into diagnostics through our instrumentation, both for testing for the virus in qPCR and also using antibody-based testing. And then finally, we're helping our customers scale up in manufacturing of both treatments and vaccines. That we're moving just as fast as we can to support their work, and excited to see some of the vaccine trials begin this week in the US. The next slide. So in terms of the diagnostic testing, about 50% of the COVID-19 testing today around the world is done on Thermo Fisher technology. We've scaled our manufacturing from February, March, when we're about 500,000 a week. We're currently scaling up and somewhere around 5 to 10 million a week, and have the capacity to scale further than that as we come in and prepare for the coming weeks and outbreaks. We're using qPCR, which is regarded as the gold standard in diagnostic testing in terms of sensitivity, in terms of accuracy. And this test has been authorized in the US in March 13th by the FDA for emergency use, and by 51 other countries around the world. So with that, let me turn it over to Dr. Wu, who will take you through some of the considerations and landscape in the testing environment. Dr. Wu?
And thank you, Thermo Fisher and Everly Well for sponsoring this webinar today. So these are indeed tenuous times, and I'm excited that I'm able to communicate the various testing modalities to you all as you begin to think about opening up your company, your what you do, so that we can all get back on the track of good economic health. So this slide here just summarizes, in case you've been living in a cave, what is coronavirus and COVID-19? So coronavirus is so named because it does contain crown-like spikes. These spikes are essential for the binding of the virus to our cells, and when that happens, the infection begins. It's not something new, the coronavirus 2, or so-called COVID-2. There have been several other coronaviruses over history. Unfortunately, this one is not as is not similar to a common cold, but it is obviously much more serious and is related to this disease that we know as severe acute respiratory syndrome. Testing is critical to controlling the spread of the disease. There are two kinds of tests that we can talk about. There are those that are diagnostic. They allow us to determine if an individual is actively infected. This looks for the presence of virus particles or the presence of virus nucleic acids. The second tests are what we call serological tests, because they look for the presence of antibodies, the presence of an immune response that our body makes in conjunction with an infection. So these are very different tests. They tell us different things, and I want to sort of go through the differences. So in the molecular test, of which 82% of all of the FDA approvals under their emergency use authorization is for diagnostic purposes. Most of the testing involves amplifying RNA, which is part of the nucleic acid species of the virus itself. There are a number of different sampling areas that are used. The most common is the nasopharyngeal swab. This is a very long swab that goes up and through your nose and into the back of your head. I've had it done. It's very painful, but at this moment in time, it is still the gold standard or most accurate. We recognize that some people are hesitant to have a nasopharyngeal swab done on themselves because of the potential for discomfort. And therefore, we have been involved with looking at alternative sample collection modalities, ones that are not painful, such as the nasal swab, which is a short swab that only samples the mid portion of one of your nostrils and doesn't go very deep, or just looking at your oral fluid or saliva. These techniques are probably more appropriate for individuals who are being screened, who work in a area where testing is necessary. Antibody testing, as I mentioned, looks for proteins that are produced by our bodies as a result of the infection. And the sample technique is actually very different for the molecular test. We are not looking at swabs. We're looking at a collection of blood, either through venipuncture or a finger stick. Once the samples have been collected, they have to be sent to a laboratory where testing can be done, or there are point-of-care testing devices that can be done at the site of collection. For mass screening, most of the testing should be done from a central laboratory. This slide shows the detection of various COVID-19 biomarkers as a function of time prior to an infection. We're hoping that everybody is able to maintain social distancing so that this type of curve doesn't occur for you. But should you become infected, it will take somewhere between 5 to 14 days to see a positive virus. The onset of symptoms also takes a few days, but of course many individuals don't ever develop symptoms. So the viral load as measured by a molecular test is shown in the pink slide here. Some individuals will continue to shed virus long after they have been infected, even beyond the 14-day window. It is unclear whether or not these individuals are infectious or if they are shedding viral particles that can be detected but are not necessarily viable. The right side of this curve indicates the response of antibodies. And there are several different types of antibodies that our bodies make. The IgM and IgA are subfractions of the total, and they appear in blood usually 1 or 2 days before the other class of antibodies, the so-called IgG antibodies, appear. And so if you have an IgM positive and an IgG negative response, it means that you've been affected relatively recently. The IgM and IgA antibodies, as shown in this slide, decline to baseline levels over time. We don't know exactly how long that takes. We've seen some individuals have declining levels within a month or two. The good news is that the IgG antibody persists for longer periods of time. Again, not sure how long. We haven't had the coronavirus in existence for longer than 8 months, but we're hopeful that this antibody will be more like antibodies that we see to other viral infections like hepatitis, where antibodies stay on for many years, and not like the antibodies that we get in response to influenza, where they wane after a few months or a year. So in order to get us back to work, we have to perform testing. And testing is not perfect. There are many things that we have to consider when selecting the best tests, the best approach for a particular situation. We have to be mindful of how long the test takes to do a result. I get complaints all the time. Somebody says, well, how come it takes so long to get a result? Well, most of the tests, the most reliable tests, take 6 to 8 hours to get a result. It's not something that can be done very easily if you want to get the best results. We're also concerned about accuracy. We want to make sure that the tests produce the most accurate result possible. This is regards to the test's clinical sensitivity and specificity. Clinical sensitivity refers to the fact that we don't want a test that picks up the other 6 coronaviruses that aren't part of the current pandemic. Those would be false positives. Most of the tests that we do now using the molecular PCR methodology have excellent clinical specificity. They do not pick up the other coronaviruses. However, there are differences in clinical sensitivity between these different approaches. If we use a nasopharyngeal swab, we will get what is probably the best result, but that is not a procedure that should be done on everybody. And so it is the reason that we're looking at alternative sample types, such as the oral fluids or the mid-nasal swab, that produce almost as good of results, but are a lot more convenient and a lot more comfortable. So the clinical sensitivity refers to how well we can detect the presence of the virus in patients who are infected. And there are different platforms that have different sensitivities. Some of the point-of-care platforms have been in the news for having slightly less sensitivity than the tests that can be done through a central laboratory. So these are some of the things that we have to consider when putting together a testing program. So the biggest problem that we have as a nation is shown on this slide. The CDC estimates that 40% of individuals who are infected with SARS-CoV-2 are asymptomatic. And so these individuals cannot be picked up by symptoms questionnaires. They don't have sore throats. They don't cough. They don't have body aches. Their sense of smell is intact. They don't have a fever. These individuals can only be detected by testing. This is why we are here today. If you are going to return your workers, they need to be safe from each other, and the only way to ensure that safety is through diagnostic testing using molecular devices. But just to be 100% sure, testing is not the final answer, because there can be problems with testing, because there are limitations. An individual who is negative for PCR does not necessarily mean that they haven't been infected or could still be infected. And even individuals who are positive and have been quarantined for a period of time and return to work could still get reinfected or can infect others. And so it is a personal responsibility for everybody to maintain safe social practices. This includes wearing a mask, making sure that you maintain social distancing. As everybody has said, in my facility where we are dealing with patients, it is a requirement that all of our healthcare workers, in addition to wearing personal protective equipment, masks, and gloves, they also have to wear face shields. And that might be an alternative for some of your employees who necessarily have to work side by side with your colleagues. So there will be an opportunity to discuss and question testing at the end of our presentation. But what I'd like to do now is turn the podium back over to Mark Stevenson. Mark has a dual role within Thermo Fisher. Not only is his company responsible for producing the tests that we use and other laboratories use, he has had to open up his company very early in the pandemic, allowing his employees to return to work so that they can provide the tools that we need. And so his dual responsibility is to protect his healthcare workers, and he is here to tell us the things that Thermo Fisher had to do that could be a model for everybody else. Mark?
Thank you, Dr. Wu. It's helpful to get everyone grounded to the same starting point on what we know so far. I'll turn it over to some of the practical steps we've thought about as we went into our focus on diagnostic testing and what we see the value of testing. You know, for the purposes of today's discussion, we will focus on what's given to be allowed by the Equal Employment Opportunity Commission and also what's actionable, so very pragmatic in our approach. And, you know, the key point we start with, as Dr. Wu just mentioned, is that testing is really the only mechanism to detect asymptomatic cases. I'll talk about what Thermo Fisher's approach has been in addition to this, but I just wanted to make that such an important point in this disease and outbreak that we've had to face. So, you know, 4 things we're seeing that implementing a testing program can do for our employers. You know, first is the safety of all our employees, keeping people from contracting the virus, ties to a continuity as well in point 2 of productivity. So we've worked very much during this period as one of our guiding principles to have employee safety, but having business continuity has also been important for us, consideration as we continue to supply the important work that our customers are doing. We've also found that employee confidence is enhanced when testing occurs. And we're also seeing this as a direct request from some of our customers. They want assurance of some of our field-based commercial people, service engineers, that as they come out to visit, that they're also safe to visit their sites. So I'll discuss the value that we've seen in our own employee testing and colleagues in our programs that we've initiated. So let me continue on first, though, to say that testing protocols really should be unique to each organization. So I think while I can share with you today some of the guiding principles we've thought about, and as we've engaged with some employees, maybe some even on this call today, who've already started their programs, what we found is different use cases, and you will all need to design your own program. But I did want to lay out 6 cases that we've seen that sort of bucket in how we see different employers using testing in the workplace. So clearly on the left here, you see protocols that essentially are centered around known cases, where on the right, the 3 there move to more proactive testing. You know, clearly suspected incident management and recovery return are all critical to start with. We also find increasingly employers are looking at spot check. They will often start with the top of their workplace baseline, and there may be some level of routine depending on the employer. We're seeing some want to test daily, others weekly, but more frequently it's using a statistical approach driven by various inputs, including prevalence, geographic region, the site of the site, and sort of tolerance for outbreak in that site. What is the activity from a business perspective in that site? So clearly within an organization, you might have different use cases. employees or even back to school and students as we start to also engage with different colleges discussing what it looks like back in the fall. So the next slide, what I tried to outline was designing the protocol for your organization and sharing with you a little bit how we've thought on the testing protocol, these factors of the local disease prevalence, the facility, what measures are in place already, the type of work, and is it possible to social distance, and then what are the individual risk factors that are involved. One of the things we found early on was, employees carpooling in. We've seen some studies of employees using public transport coming in. Some employees are separating those into different groups as they come. Based on that's an increased risk profile coming to work. And then clearly within the safety protocols and work, we're absolutely supporting distancing and face masks. Important for the employer is to also work through the protocol, what happens if someone is suspected positive, and what are the next steps. We have worked through that, but in this seminar, we didn't have time to cover all of those details, exactly who are the decision makers, what are the considerations, both legal, HR, the implementation. But we plan a second webinar where we'll talk more about the operationally this testing program as you get set up to start the testing. Go to the next slide. So, the case study with Thermo Fisher, we certainly from the beginning took what would be regarded as defensive actions. We did reduce our on-site staff. We've rearranged to ensure social distancing in our offices and our cubes, added hygiene from the elevators to the restrooms, encouraged face masks as mandatory and actually handouts on entry in the building. We do have fever screening at the main sites, visitor guidance, as well as a stand-up daily policy on each site and stages of reopening. So with that, we've continued that, but then thought we would add testing to that protocol, not as a replacement, but as an additional aid to keeping our workplace safe for our employees and ensuring our business continuity. In terms of the protocol we decided to adopt, as I mentioned, and some other employers have done this, we started with a workplace baseline. We started with a pilot actually in June, where we tested in the US all of our field-based service engineers, including some of our new hires. Particularly, we thought they were at risk because they were re-entering some of our customer sites and wanted to reassure our customers that it was safe. We also decided to test some of our larger sites where we were manufacturing pharmaceutical products and had critical supply chains, and carried on to test all of those workers at the site. Our intention following that testing is to do spot checks. We're taking an epidemiology-based, science-based approach to routine testing to both monitor the site health and maintain a safe workplace. And we'll also have in place incident management. So if we do have a positive test, we set up a procedure to track and trace of the colleagues on site, separating the space as necessary. We believe this approach is right to meet the obligations of our colleagues and customers. So far, when we started the testing across some of our sites in Pennsylvania and Ohio, across our field organizations in June, but actually some of the prevalence was a little lower, we did get about a 0.5% positivity rate. The vast majority of that were asymptomatics coming into work. So our data provided, even in a well-controlled work environment, we were finding positive cases that were asymptomatic in our initial pilot. And we're just starting our second pilot here now in July. In terms of the other practical steps you all would need to think about, in this testing, when we talk about it, several steps broadly involved in the process. The first is obviously the test order, so determining the eligibility of the employer to order, what consent might be needed to return the results back to the employer, whether in certain states we'll need physician orders. Not all states, but some do, and generally required at least for asymptomatic testing. Some of that guidelines continue to evolve from CDC and other guidelines out there. As was mentioned by Dr. Wood, also different types of sample. Most of the sampling we see today are done still through nasal swabs. We do see some self-collection available, and obviously that can ease things, and if employers have a healthcare provider on site, that can also make it more straightforward. Then needs to be transported to the lab. We certainly think it should be rapid in the lab. Typically we want this testing back within 48 hours or less, so that we can get a fast turnaround time, and if necessary, isolate and close down that area. And then results, many components here for the organization to consider, whether we're giving individual results back or whether this is a screening or surveillance program, how we think about the employer dashboard and notifications, as well as mandatory reporting required to the government. So various considerations you will need to work through. And this was one of the things that sort of got us to start to think about, is there a more comprehensive way that we could certainly work with partners that could help us bring together this end-to-end solution. And during the last couple of months, we began to see those partners evolve. And I'd like to turn it back actually to Daniela, as we'd asked her to leave our employee testing group. And as she's led that, she's also worked in identifying a partner she'll now introduce to you. Daniela?
Great, thank you, Mark. So Thermo Fisher is going to be working with a partner named Everlywell, who you'll hear more about today from Julia. Everlywell is a digital health company, and they've got a great solution, we think, to provide an end-to-end experience, and we'll talk more about that. Moving to the next slide. So just explaining a little bit about the solution here, Thermo Fisher has what's called an emergency use authorization, or EUA, for a qPCR test known as TaqPath. And Everlywell also has an emergency use authorization for a home collection kit. During this pandemic, having an authorized solution from the FDA means that the solution is authorized for use under this emergency use amendment. We're working together in conjunction on an EUA amendment now, which we expect to submit in the month of August. But in the interim, we can still accommodate testing needs that you have. So moving to the next slide. As Mark said, we really believe in the importance of testing, and we initially started on the journey purely so we could test our own employees. We realized, though, during this process, and with many inbound calls from partner organizations, we realized that this was something others may find useful as well. And so we went on a journey to try to find an experience that would provide an end-to-end opportunity for our partners. And we believe that Everlywell has just that, for the following reasons. First of all, the swab used is very quick and painless. It's the short nasal swab, not the nasopharyngeal that we talked about earlier. The self-collection that's used enables us to serve the needs of our entire employee population. So whether you're remote and working in the field service area like my team does, or whether you're co-located with other colleagues in a site, the solution is scalable for all of those use cases. And it has a national footprint. So as an employer, it's easy to build one contract for all of the staff that you have in multiple states. In addition, the solution can be leveraged for many use cases, as Mark highlighted, including the spot check situations, routine testing, or baseline testing. We also get to receive the reporting required to check the status and the results of our colleagues. And the solution is supported, most importantly, by a network of physicians, ensuring that the tests are ordered and the results are reviewed by certified physicians. So I'm going to turn it over to my colleague, Julia, who runs Everlywell and who's built the organization, to tell you more about their company and the solution. So Julia, over to you.
Thanks, Daniela, and thanks to Thermo Fisher for giving us this opportunity to partner on what will be a scalable solution nationally, which is so important to getting people back to work. Next slide, please, Ian. Thank you. So just a little bit about Everlywell and the solution that we provide, and why this partnership should enable significant scaling for organizations like those on the phone and on the screen today. So Everlywell is a leader in at-home lab testing and at-home test collection. We have over 35 different tests enabled by an independent physician network, manufacturing and creating kits, and a network of partner labs, all with a national technology layer that allows this to happen, seamless collection from the user all the way through to getting the results back to our users. We leveraged this platform to serve in the COVID-19 pandemic and submitted for an EUA for an umbrella at-home test collection kit, which was authorized in mid-May. It was the first EUA of its kind as a standalone collection kit that can be authorized with a number of labs, which really helps to build capacity and throughput and be able to allocate to ensure quick turnaround time for those labs that are authorized within our EUA. And with the Thermo Fisher partnership, we will be able to ramp that process and workflow up even more quickly as testing capacity continues to be a constraint nationally. To date, we have over 30 organizations that we serve, from Humana to Collective Health to universities to City of Los Angeles and other municipalities. And from an end user or an employee experience standpoint, we have a net promoter score, which many of you may be familiar with, of over an 80, which is a world-class solution. So I'm really excited to be able to bring this front end and infrastructure to the power of the Thermo Fisher technology and offer this comprehensively to all of you in your organizations. Next slide, Ian. So I'll turn it back to Daniela, but a couple of comments around why this end-to-end seamless experience is so important. So Everlywell obviously will engage with users and provide an easy end-to-end digital experience and a simple collection kit, everything from customer support, overnight shipping, text messaging updates, email updates, et cetera, for your employee base. And as Daniela mentioned earlier, we also have with consent, employer dashboard reporting, and of course, state and local federal agency reporting for positives as required. So we really handle the end-to-end solution to make it easy for you to test your organization. Daniela, over to you.
Great, thanks. So we feel that Everlywell has a seamless front-end partnership opportunity here to set up a testing infrastructure. Our skill set is really in making sure labs have the supply needed of our high-quality COVID-19 qPCR diagnostic tests. As Mark mentioned earlier, we're really more behind the scenes as we're a very large manufacturer of the technology for the lab in fighting this pandemic. And qPCR is considered to be the gold standard in diagnostic technology. So while we've embarked on this partnership looking for an option for ourselves, we thought this might be something that you might be interested in as well. So moving to the next slide, if this does sound like something that would help you, please visit this webpage to learn more. When you visit this webpage, you can learn more about the solution, and you'll also be able to complete a form indicating your interest, and Everlywell will be following up with you directly. We're very eager to support your testing needs. Everlywell is ready to accept employer testing contracts now with high-quality qPCR testing, which includes elements of the Thermo Fisher COVID-19 portfolio in many cases. So with that, we hope this was helpful as you think through testing for your organization. As I mentioned at the beginning, we will be having further discussions and further webinars tackling other issues in the area of employee testing. We'd like to now open it up for questions, which you can either type into the chat box or you can raise a hand and ask live. And in fact, while we've been here, I've gotten a few through the chat, so I'll go right to that. So the first question, I think, will be for you, Dr. Wu. And the question is from an audience participant who says, the key value of qPCR testing is detection of asymptomatic carriers and pre-symptomatic individuals. What do we know about the duration of asymptomatic positivity plus the potential of those individuals to spread the virus?
Well, thank you for that question. Individuals who are asymptomatic may, in fact, have lower viral loads, and in that scenario, we think that they might be less infective and perhaps the duration of their infection could be less. The reasons why some people are symptomatic and others are not not completely known, but it could be related to genetics, or it could be related to the presence or absence of comorbidities. But it also could be related to an innate ability of an individual to fight that infection. And so we're hoping that these individuals might be a little bit safer.
Great, thank you. The second question comes from another audience participant who asks, and this I think is for you, Mark, does Thermo Fisher have an approved and published protocol for sample pooling that we can use in the lab?
Yeah, we've not yet approved a pooling protocol. We have worked on one of pooling about 5 samples. For those not aware, sort of the technical details. So here, we're taking a group of employees, pooling them together, testing together. If there is one positive in the pool, then you can report out. So we're seeing a few of our labs starting to do that. We do intend to submit to the FDA a pooling protocol. Once it's approved, we'd certainly let everyone know. There are some downsides in the turnaround to pooling, so we're just careful on making sure we get it right and we don't lose any sensitivity.
Great, thanks, Mark. Next question is for you, Julia. Question is, do you partner with a physicians network who can call the positive participant with their results rather than seeing their positive result in a patient portal?
Thank you for that question. Yes, the answer is that every positive receives a telehealth consult from a board-certified physician automatically. You also have the option, if you are negative, to reach out to the same physician network if you're concerned about the other symptoms you're having or potential exposure. Obviously, you also do get your results in a digital platform, but you have both opportunities to ensure that you get not only the written CDC protocol for quarantining and isolating, but also then a discussion with a physician.
Great, thank you. I have another question for you, Julia, and I'm going to combine you into one. Part of the question is, what is the turnaround time on the testing? And then there's also a question on the pricing in the program.
Absolutely. So the turnaround time, and this is really important to keep in mind, is that the turnaround time at the lab is 48 hours, contractually guaranteed across all of our lab network, and we are adhering to that even today. However, there's an interim step where the samples, a little bit to Dr. Wu and Mark's points about how where samples can be run in high complexity labs or on site. These are PCR tests run in a lab, and therefore there is an overnight shipping component to the lab. So that adds an additional 24 hours. So it is, but once it arrives at the labs, it is 48 hours, and we're actually delivering oftentimes within about 33 hours on average. So it's a really rapid opportunity for testing. One of the benefits of having a network of labs is the ability to track and manage throughput in a different way. And so that's been a big advantage for us as we've managed the volume and complexity of throughput here with multiple clients. And then to handle pricing, Daniela, thank you. We have priced this at no profit to Everlywell. What that means is that we've been transparent about our costs. The cost of our end-to-end experience are published on our blog. It is $109, including overnight shipping, individual overnight shipping, and including the physician consultation and requisition. And then, of course, all of the processes. We are committed with Thermo Fisher to bringing that cost down as much as possible and making it as affordable as possible using new potential techniques as they become authorized, like pooling, et cetera. So we're actively working on that as well. But at the moment, it's $109 per test.
Okay, great. And actually, I'm getting a lot of questions about this particular topic, and then I'm going to go back to Alan. But Julia, one more for you.
Sure.
Are the Everlywell tests available to order in bulk? And if so, is there a minimum quantity to order?
Thank you for the prompts. I am sure to mention that. They are available to order in bulk. To be clear, there is an eligibility requirement through our EUA, which partners adhere to. It includes being sure that groups and workplaces are, at work and that they're testing that way. So you can't just order in bulk just any number that you want, but we go over that with you, and it's generally available to all use cases that need it. You can order in bulk, we can drop ship, or you can submit via an API in order to have the most seamless way of managing your particular needs for your workforce. In addition, the minimum order quantity is around 500. We have accommodated partners from anywhere from 500 kits all the way up to hundreds of thousands. So we have flexibility in rollout, and it can be it can be a one-time order, it can be over a period of time. We just like to ensure that we understand utilization of tests, again, to be able to manage this incredibly fast turnaround time, our throughput with our labs, and also ensure that we're using scarce components in the most valuable way for testing across the country.
Great, thank you. Next question is for Alan and Mark. Could you please comment on the accuracy of the short nasal swab versus the traditional nasopharyngeal? And then also, what is the sensitivity and specificity of the Thermo Fisher qPCR test?
Well, I'll answer the first one and refer Mark to the second one. The accuracy of the mid-nasal swab is almost as good as the nasopharyngeal. It actually depends on the viral load. And if you are somebody who has a lot of virus, then it doesn't really matter where the sample is. It really kind of matters when it's right at the edge, and sometimes that might not necessarily be a true positive. So there is a little bit of compromise, but I don't believe it's great.
So in terms of the test itself, so first, it's a highly specific test. We sequence the genome of the SARS-CoV-2, targets the S protein and the nucleocapsid protein, and we detect 3 regions across that in our assay, so very specific. And then in terms of sensitivity, our sensitivity, we talk about in terms of a limit of detection, which is 10 genomic copies of the virus. To put that into perspective, you've heard Dr. Wu talk about viral load, and I see one of the questions is, do you recommend testing symptomatic patients? Think about a symptomatic patient. Typically what we're seeing is 1,000 or more copies of the virus. So if you think about we're detecting the limit of sensitivities at 10, we pick up very low levels of sensitivity in that 10 copies. That's the cutoff we have in the test, and that's what the FDA approved.
Great, thank you, Mark. Maybe one more question for you, Mark. There's a question related to when doing periodic or random testing for employees, what do you think about the recommended frequency of testing? How do you think about that? Maybe you can comment on how we think about it at Thermo Fisher. But the general question is, how often do you think the testing should be performed?
Yeah, that's a very hard question to answer and define. And as I tried to lay out multiple considerations, so to give you some examples, we're seeing some employers, for example, if you're running a healthcare business where, for example, you might be doing a kidney transplant or monitoring patients, you really want to monitor those staff every day. For our own employees, and we've seen this, for example, it's sort of been publicized a little bit on sort of nationwide shipping and distribution. It seemed like once a week is what they're saying. It's really a combination then for us. We're going to do both the baseline and then look at the prevalence. So at our headquarters in Boston and Massachusetts, Connecticut, maybe where it's lower prevalence at the moment, it'll be less frequent based on the statistics. In the South and the West, we're going to be testing more frequently based on the prevalence at the moment. So that's the algorithm, and certainly that maybe a third webinar, I think, Daniela, to share statistical approaches that you can do on frequency of testing.
Great. And then another question for you, Alan. What's your view on serology testing, and how do you think about that in the testing strategies of companies?
Well, serology testing as it's currently configured allows us to determine if someone has been infected, but unfortunately it cannot tell us that an individual is immune from a reinfection. And so the value in this particular context is less than ideal. Plus, we also know that antibodies tend to wax and wane, and they decline, and they may not indicate that somebody is infected recently. it still could be negative. So at this moment in time, most people are focusing on virus testing and not antibody testing.
Great. Another question for you, Alan. A question about how does the Everly Well test here with the qPCR differ from other rapid tests?
Well, I think the difference is analytic sensitivity. As Mark indicated, that being able to detect 10 viral particles is a major advantage for looking at very low viral loads in asymptomatic patients. Some of the other devices, as I mentioned,
which give results in 50
have been criticized because they don't pick up as much virus as the central laboratory. So Everly Well has taken the approach of using the best analytical tools that are available to us at the time.
Great, thank you. And Julia, maybe one more for you. Question relates to the digital reporting. Can you talk a little bit about what the digital reporting capabilities are and what that process looks like for an individual and for the employer?
Yeah, absolutely. So one thing just to ground us in as Everly Well is HIPAA and Medicare compliant, and has been for a number of years. We work with large payers and other enterprises. And so the data security and integrity is extremely high quality. We provide results on our platform. There was a slide with a screenshot of what the digital results look like on mobile and on desktop. It tells you if you are infected. It tells you next steps. That is updated regularly, both with our EUA notification to the FDA according to CDC guidelines. You then from there can book your telehealth call with a physician as well, and have the number there to make an appointment. For employers, there is the dashboard reporting for employers that is both aggregated and then can go down to specific levels depending again on what the custom consent flows are up front that we implement for your organization, and what level of detail you want to see. For example, in some cases we use employee IDs. There's restrictions and roles based on who needs to access the data. And then you're able to also see where kits are, which is really important. So who has been tested, what's the status of each test, and when do we expect it to be resulted? And of course, then the actual results and what you can see from your population and location.
Great, thank you. And Alan, maybe one more question. Actually, this is a question that is pertinent because we got this question from our own employees when we started testing. We had some concerns about people who were concerned about doing the testing because they didn't want our company to have their DNA. How would you suggest employers respond to that in this case?
Well, first of all, the tests are being done by Everly Well's lab and not by the employer. So there should be a firewall to transmit data. But more importantly, the methodologies for doing a viral PCR is very different from looking at human DNA. The reagents that are used in the Thermo Fisher device is targeted specifically to RNA sequences that make up the virus. And unless you have thorns on your head, it's not likely that you have those exact sequences. And so there's nothing in your human genome that's going to be picked up. I can tell you that, and Julia mentioned this too, that they're HIPAA compliant. If you violate these HIPAA regulations, you are subject to civil penalties and potentially even criminal offenses. So we take privacy extremely importantly here, and I really believe that there is no chance that an employer can have information on your DNA from the results of this test.
Great. And maybe one final question, and I'll wrap it up with a closing comment. Julia, there was one question about the availability of testing outside of the United States. This is Canada.
It's a great question. I think we are certainly interested in partnering and pursuing that together. It is not something that we have begun to tackle from a regulatory standpoint, but are open to it. But right now it is available in the U.S. only, and for the next few months and foreseeable future will remain so.
Great. Okay. Well, we really want to thank the audience today for their participation. I had several questions about whether this material can be available for you to share with your colleagues and your team. It will be posted And we will be following up with everyone who registered for this. You will get a link to the presentation, as well as the ability to log in and re-review the presentation or send it to others as well. We will also include the link to provide you so that you can directly interface with the form we talked about for any interest you might have in this testing solution. And we will be planning for our next webinar, which will focus more on the practicalities of how we actually implemented the testing, what decisions we had to grapple with to do so, the employment and legal regulations, and we will be leveraging team members from Thermo Fisher in our human resources and environmental health and safety departments to help communicate directly, because they're the ones on the front lines who actually had to make the decision. So stay tuned. We'll be communicating with all of you about that. And if there's any other topics that you have interest in, feel free to also communicate in response to that email that we send you with those topics. So with that, we will conclude today's session, and we thank you all for your engagement and wish you safe health. Thank you.